Good morning, good afternoon. We're just going to wait till a few minutes past the hour so we have a little more of a quorum as people are still filing in. So thanks for those of you who are on time. Thank you for everyone who's joined. We'll give it at least another minute before we get going, since folks are still filing in. Good morning, good afternoon, everyone. Thank you for attending. I'm Ken Mayer from the Harvard CFAR and Fenway Health. I co-chair the Antiretrovirals for Prevention working group with Patrick Sullivan, who will be our featured speaker this afternoon. We are a series of bi-monthly, sometimes monthly webinars to highlight some of the key developments in this area. Just want to call your attention in the chat. There's information for next month's speakers who are going to be Connie Kellum and Jen Velosa. We're talking about some of their really interesting work. But it's a pleasure today to introduce Patrick Sullivan, who's a professor of epidemiology at the Rollins School of Public Health at Emory University. Patrick has really been a thought leader in a number of areas in HIV prevention. His career has gone from Emory to the HVTN, the CDC, and back to Emory. In addition to being a lead investigator in numerous studies, Patrick is the editor-in-chief of the Annals of Epidemiology, and the work with his PRISM group has really been landmark in terms of being able to use geospatial data to understand the intended and unintended consequences of the rollout of different prevention technologies. So we're very fortunate to have Patrick with us today to talk about using local PrEP equity metrics to measure success in PrEP scale-up. If you can please put any questions you have in the chat as Patrick gives his talk. We'll have time for Q&A at the end of the session. So thank you. Patrick, please take it away.
Thank you, Ken, and thanks to all of you for attending. I really genuinely appreciate the opportunity to share this work, which I'll present today on behalf of many colleagues, and you'll see them acknowledged throughout this talk. I do have research grants and consulting fees from Gilead Sciences and Merck. So I just want to start out by taking a moment, as I probably will for the next coming months or year, to express my gratitude to Dawn Smith, our dear colleague who left us last year, for her thought leadership and gentle guidance and collegial rigor. And her inputs are really woven throughout what I'm going to be presenting today. And we miss her greatly and want to honor that by building on, the passion that she had for both PrEP as a biomedical intervention and for doing it in the right way. And just in recognition of the understanding in this group that we think about antiretrovirals both for treatment and prevention, I really wanted to start out by saying, although sometimes we go through these analyses and we feel like we have revelations, I always want to, honor where those revelations came from and everyone who had them and talked about them before me. So I had the honor and pleasure to work with Steph Barral and colleagues on this commentary in Lancet HIV a couple of years ago, which really thought about the disconnect between individual level and population level benefits HIV prevention benefits from antiretroviral treatment. And so I just highlighted a bit here, and I'll show you a bit of data. But, several years ago, Steph was really sort of putting forward this idea that what happens when you have experimental data that show, pretty profound, impressive effects, in this case, of treating people living with HIV on onward transmission. But then when you scale that up, that same magnitude of benefit isn't realized. And he really made the point that we need to pay attention to the heterogeneities of HIV acquisition and transmission risks that exist in people who are at risk for and living with HIV, even in generalized epidemics. And if we don't do that, then we'll compromise the effectiveness of these interventions. And just, by way of data in that presentation, Steph pointed out that in the sort of trials of treatment as prevention, the magnitude of the reduction in HIV transmissions was really substantial. But in the population-based studies, to increase the extent of treatment and viral suppression for people living with HIV, there was a much less profound effect. And so these are just, again, by way of perspective, for treatment as prevention, Steph sort of advocated the idea of core group theory, that prevention gaps among a relatively small group of people who are at most risk of acquisition and transmission can actually sustain an epidemic even when we have good interventions. That viral suppression within serodifferent partnerships can avert an infection with that direct partner, but also has indirect benefits to the partner's partners. So the models, might predict that these onward benefits would help really substantially reduce transmission when we treat a person for HIV infection and suppress viral load. However, the indirect benefits stem from the way prevention, among a few, can go along a chain. And it's especially impactful if we reach the people who are in greatest need of these interventions. However, if we sort of approach the distribution of these prevention options on an equality basis, and I'll talk a little bit more about this, we might actually reinforce disparities. We might actually grow disparities in different groups if we are not paying attention to getting these interventions to the people who need it most. And this line from that paper said, results from trials and models are consistent with core epidemic theory in that from an HIV prevention specific, knowledge of for whom we are providing treatment is more relevant than for how many people we are providing treatment to. So I just want to acknowledge with humility that these ideas are ones that have been around, but we've really been working to apply and quantify some of these effects, particularly with respect to PrEP, which was approved in 2012. We know that the risk of acquisition of HIV is not homogeneous in the US, that Black and Hispanic people have higher rates of new diagnoses, that people in the South have higher rates of new diagnoses than people in other regions. So health equity really asks us whether we can align access to PrEP and prevention interventions in a way that's proportionate to the impact of a health concern in the population. So how do we measure success and opportunities in PrEP programs? I'll show you some information to suggest that right now we're largely counting the numbers of people on PrEP, and we may do that within certain subgroups. We may also think about the prevalence of people on PrEP where we have good denominators. Another indicator is the percent of people with indications who are on PrEP. And today I'm going to introduce, if you haven't met it yet, the PrEP to need ratio. And I'm going to reintroduce you if you have met it. And I'm also going to talk about the PrEP equity ratio or PrEP inequity ratio, which is another way of trying to think about how we measure the idea that I just introduced, is to what extent are we getting PrEP, not just to people, but to the people who are most likely to benefit from it. So these are data from the AHEAD dashboard. This is a dashboard that presents data intended to monitor the US epidemic. And what you can see is just the percent of people with indications for PrEP classified as having been prescribed PrEP nationwide, and how that proportion has increased relative to the 2025 goal of 50%. I think part of the point here is that the way that the PrEP guidelines are written, they really are meant to identify fairly broadly, fairly inclusively people who may have PrEP indications. And within that group of people who meet that definition, there's still substantial heterogeneity and risk. And how could we characterize that? We know that it may vary by age, it may vary by sex, it may vary by region of the US, and it certainly varies by race and ethnicity. So how do we answer these questions about equity? And I think I missed my slide here is probably one that you've all seen before. So we'll make it a mental acrobats activity to keep us awake, which is the difference between equality and equity. So these kinds of metrics that we're looking at here are equality metrics, which says, we really want to have a certain proportion of people with indications for HIV be prescribed, and to have that reach a level of equal access, even though we know that the risks for HIV infection actually are different among groups, as opposed to equity, which says some groups of people may actually need higher coverage of PrEP to achieve the same outcome in protection of health. And some groups actually that have lower risk may need less coverage to achieve that same outcome. So how do we need to answer these questions? We talked about some of the metrics that we currently have, but to get to equity metrics, these are just some of the ingredients to that recipe, which are having population-based data source for PrEP prescriptions, which is the numerator. We need denominators of people with PrEP indications, targets for coverage related to the prevention outcomes, data sources for PrEP use in key populations, which we don't really get from pharmacy record data, and then these equity indicator metrics, and we need to monitor these outcomes and report them over time and in smaller geographic areas, because all public health, like all politics, is local. This is these sort of aspects are places where Dawn really has led the way and been the thought leader and the champion of these kinds of data sources. So just walking through some of them quickly, I'll mention that the data I'm going to share today are PrEP data as documented in commercial pharmacy data, and we've just I've just finished working with data from validation of these definitions. But the issue here is obviously that initially tenofovir FTC was used for treatment and then was subsequently approved for PrEP. And so when we look in commercial pharmacy data, we have to distinguish whether someone who's receiving this prescription is getting it for treatment of HIV, for post-exposure prophylaxis, for off-label hepatitis B treatment. And the solution was to use diagnosis and procedure codes to rule out those other uses for TDF-FTC, and then what remains was presumed to be PrEP. And this definition using commercial pharmacy data was validated in two settings. First was in an EMR database, the Quintiles database, where the people prescribed TDF-FTC were determined to be PrEP or other indications by clinician review. And then all patients identified as PEP, chronic hepatitis B or PrEP, plus a 1% random sample of people living with HIV were put in a pool to test this algorithm. What we found was that the definition that uses a definition of exclusion for PEP, chronic hep B, and to have what remains, and people living with HIV and have what is remaining be PrEP, had substantial agreement with the gold standard, and you can see the sensitivity and the specificity here. A second validation was done in a clinic population of a community health center, where the cases were people who were known to be in the PrEP program, and administrative review of records was used to identify cases. And again, this kappa value of 0.64 it corresponds to substantial agreement. Here, the sensitivity is a little higher, the specificity is about the same. So these are the ways that we identify PrEP data from commercial pharmacies. The denominators of PrEP indication was led by Dawn, Michelle Van Handel, and Jeremy Gray when he was a postdoc at Emory and is now a leader at CDC. And Jeremy really championed a method to use multiplier methods to identify the numbers of adults with PrEP indications by risk, race, ethnicity, and jurisdiction. And one of my themes here is that we need to be thinking about these metrics at the local level. Their estimate was about 1.3 million US adults with PrEP indications, most of whom were MSM. And if you just look at their calculations, which take into account these sort of differential risks by race, that includes about 500,000 Black Americans, 282,000 Latinx, and among heterosexuals, sort of a 2-to-1 ratio of women to men. And then I wanted to also sort of acknowledge the work led by Sam Janess, which led to targets of sort of PrEP coverage needed to achieve certain HIV prevention outcomes. And so, when you ask epidemiologists how many people need to be on PrEP to reduce HIV incidence by 1/3, the epidemiologist will always say it depends, which is annoying. And then you say, what does it depend on? And the answer here is it depends on the risk population and adherence. And so we're going to talk some about risk populations in a moment. But essentially, the more closely you direct programs to serve people at high risk of HIV acquisition, the less PrEP you need to achieve certain incidence reductions. But adherence also plays in. And so Sam's model suggested that a 40% coverage of PrEP among indicated MSM would result in a 33% reduction in HIV incidence, or a number needed to treat of 25. And through the data that we've evaluated, PrEP uptake is falling well short of this goal. I also mentioned data triangulation. This is work led by Travis Sanchez and Maria Zlatowiska. And these are from the American Men's Internet Survey, which Travis has been running for many years, almost a decade, of a national web-based survey, behavioral survey of MSM. Think of it like NHBS in the rest of the country. So we had a chance to look at data from this study through 2017. And what we found was, just if you look at PrEP, the blue line here is PrEP awareness. The left panel is white MSM. The right is all other MSM. So just PrEP awareness, this sort of increased through 2017 and ended at quite a high level, about 82% of MSM aware. And that was pretty equivalent in the non-white MSM. This is the willingness to use PrEP, which sort of gradually increased in both groups. And this is the PrEP use, which increased from 2% to about 20% in the white MSM and 2% to 19% in all other MSM. And at the time, with an equality lens, I think we were surprised that the prevalence of PrEP use in men responding to this online survey was roughly equal for white, Hispanic, and Black MSM. But here now is the figure that I mentioned before, which is that we were looking at an equality kind of conclusion. And this slide, which many of you have seen some version of, just says that if we give everybody a step up, that really works for some people, but it really is misdirected for others. And that what we should be aiming for is an equitable level of sort of reduction of risk so that everyone ends up with the maximal sort of opportunity for health. And so Aaron Siegler, I think, took a big step in this direction by developing and publishing the PrEP to need ratio, which just says basically what I said in words rather than equations before, which is that we really need to think about not just the number of PrEP users in a group, but the number of PrEP users relative to their epidemic risk, which he quantified as number of new HIV diagnoses. And so the intuition here is that more PrEP use is needed in groups that have more diagnoses. And so this isn't an absolute indicator. There's no target for programs of what the PNR should be, but generally the higher the number is, the more equitable PrEP use is. So just looking, for example, if we look at the prevalence of PrEP users in the US, we might conclude that the South is doing, fairly well. Only South Carolina in the sort of lowest quintile here, and the upper, Midwest is actually really underserving their populations. But if we sort of norm those levels of PrEP uptake to the risk or to the epidemic need in these areas, it becomes evident that the South actually needs much more PrEP because the risk to our residents in the South is much greater. And the sort of plain states here actually look relatively better because they do have less PrEP, but they also have much lower new diagnoses. So PrEP to need ratio is a way of comparing apples and apples where the risks of HIV infection are not the same. And so Aaron led further work to ask about the associations of PrEP DAP, PrEP drug assistance programs, and Medicaid expansion at the state level, and this outcome of PrEP to need ratio. And what he found was that the PrEP to need ratios were likely to be higher in states that had either PrEP DAP or Medicaid expansion, and states that had both actually had even higher PrEP to need ratio. And just to keep in mind that either of these policies moves towards PrEP equity, or PrEP equality, but combined they really move towards equity. So I want to go now directly to the sort of PrEP equity part of the talk. So we use these data, as I described to you before, to enumerate PrEP users by race and US Census region. A major concern or a major limitation of these data that I want to put up front is that the race ethnicity data in these commercial pharmacy data sources are not very complete. Only about a third of the PrEP users in the data set in 2021 actually had race ethnicity data. And so to estimate the total users by race each year, we assume that the racial distribution was the same in the PrEP users who were missing data as those with reported race data in the smaller geographic units that we'll discuss. And this is almost certainly not a right assumption. And so one of my conclusions will be that we need better methods to get these data. So as I mentioned, the PrEP to need ratio is this metric of the number of PrEP users divided by the number of diagnoses in that group the same year. So in these data, the 20 and 21 data reflect the PrEP users in those years over a denominator of newly diagnosed in 2019, since those were the most recent available diagnoses. And then this ratio just describes, again, the distribution of prescriptions relative to epidemic need. I showed these slides at the recent IAS conference, so I'm going to show them again, but if you saw them there are some new data that I'll go a little bit further. So just to orient you a bit, in this slide, there are 4 quadrants for the 4 regions of the US, the Midwest, Northeast, West, and South. And these numbers are those PrEP to need ratios. Keep in mind what I mentioned before, which is, if we look in the South, this number would suggest that for every new HIV infection in the South, among white Southerners, we have 20 people on PrEP. That's the interpretation of that PNR. And when we look at these by region and race, a few trends, consistent trends emerge. So the first is that the South has the lowest equitable PrEP use for all 3 racial ethnic groups compared to the other regions of the US. Next is that the Northeast, for every racial ethnic group, has the highest equitable use. The next observation is that within each of these quadrants, there are lines for white, Hispanic, and Black people. And in each of the 4 regions of the US, the extent of equitable PrEP use for white residents is higher than that for Hispanic residents, which is higher than that for Black residents. And the last thing that's concerning is that this blue bar represents essentially the inequity in PrEP use, the distance between the PrEP to need ratio for white versus Hispanic and Black residents in these regions. And if we look in 2016, 2019, and 2021, the inequity in PrEP in the United States has actually increased across this time. And you remember I said when in the introduction that Steph had sort of said if we take these interventions and we deploy them in a way that's not equitable or sort of this doesn't reach those who would benefit most, then we run the risk of actually increasing disparities in the epidemic. And so just to give you all these sort of regional graphics are available on AIDSview, but just to give you an idea in 2021, that actually you can see just at a categorical level that the PrEP relative to need is higher in the white, lowest in the Black, and intermediate in the Hispanic. So I'll next introduce the PrEP inequity ratio, which is, or the PIR, which basically says, can we quantify the extent of the inequity in this pattern of PrEP use? So if we look, for example, for a white to Black or a woman to a man to woman kind of ratio, we can quantify the extent of the inequity. So here, higher values indicate more inequity. And I would say programmatically and in terms of prevention efficacy, we should have a target value of 1, which is that each group's level of PrEP use is exactly in proportion to their risk in the epidemic. So I would just want to point out on a theoretical basis, the sort of PNR, which is the number of people on PrEP to the number of new diagnoses in those years, and the number needed to treat, which came out of Sam's model that I mentioned earlier, which is the number of people on PrEP to prevent 1 new HIV diagnosis. And remember that Sam found that that number was in the, in the order of 25, maybe. So if we look now at this inequity ratio, again, this is the sort of magnitude of the inequity. This line represents the white-Black inequity. So the equitable use of PrEP in Black people in the United States is about 10% of the equitable use in white Americans. And similarly, the equitable use of PrEP among Hispanic people in the United States is 80% less than the equitable use in white Americans. And when we make that same kind of comparison by sex in the United States, we see that these are the PrEP to need ratios. This is the PrEP to need ratio for men, which is about 13.3 men treated for every 1 new HIV infection in men versus 5 women treated for every new infection in women. When we look at those over in the entire US by region, broken down by region, you can see that these inequities are present in every region, and the extent of magnitude of that inequity is probably highest in the Northeast. And actually the magnitude of the inequity is a little bit lower in the South. If we look nationally at the inequity ratio, which is this sort of relative measure of the equitable use, we find that in the early years of PrEP, this rose to a level of between 2 and 3 and has kind of stayed there through 2021. So as people who want to improve health, like we need to ask why this is happening. And I just want to say a bit about white-Black PrEP inequities. And here, I think we have to talk about things like access to healthcare, proximity of PrEP providers, PrEP stigma, HIV stigma, living in areas with regressive policies, mistrust of healthcare, education. So I'll just show you a few thoughts around this. These are data published by Bisola Ojikuchu that showed essentially that PrEP willingness among Black African-American people in the United States was associated with higher PrEP density in the neighborhoods, the extent to which PrEP was used by others in your neighborhood, but also shorter driving distance. So I'm going to say a word about driving distance and physical access to PrEP. This is more work from Aaron Siegler, who developed this map of essentially drive time to access PrEP services, where you probably can't read this on the slide, but these dense red regions are regions, and if you live in this region of Georgia or these areas of the Midwest and the Plains, your drive time to the nearest PrEP provider is about 2 hours or more than 2 hours. So you can see that we have substantial areas that in which people don't have good geographic access, and I think certainly telemedicine PrEP has been an important step to address that. But again, we have to worry about interventions like telemedicine PrEP and whether they reach the populations within these geographic areas that are most at risk. My animations are a little bit off here, but I want to make another point related to Dr. Ojikutu's data, which is the driving distance to PrEP. So these are this is maps from my home city of Atlanta, and I want to point out on the left the distribution of population by race ethnicity, where here every green dot represents 500 white Atlantans, every blue dot represents 500 Black Atlantans, and I've drawn this line here, which is our Interstate I-20 and is the historical location of the railroad tracks in Atlanta. And on the right is the location of PrEP services. And so just by looking at this and without any fancy analysis, we can see that these areas that have large numbers of Black residents south of I-20 have relatively little geographic access to PrEP providers. And there have been separate analyses that have been done, and I can share them if people are interested, but actually looking at the locations of residents in Atlanta, their drive times, and the drive time to a PrEP location is associated with less PrEP uptake. The higher drive time to a treatment location for people living with HIV is associated with fewer HIV visits and a higher likelihood of not being virally suppressed. Next, I want to talk about stigma, and I'll just show you a bit of data. These are from Brian Mustansky's RADAR cohort, but just showing that PrEP stigma is experienced more acutely by Black and African American young men who have sex with men and Hispanic Latino men compared to white and other MSM. I've already mentioned to you that policy matters. These are a little bit more data from, just to remind you of Aaron's analysis, which showed that the areas with PrEP-DAP or Medicaid expansion had higher levels of PrEP coverage, and those with both had high levels that were higher still. And when we look at the places that have PrEP drug assistance programs, you can notice that they are very largely not in the US South. And when we look at the states that have not yet expanded Medicaid, also largely not in the US South. I want to say just a bit about male-female PrEP disparities and point out that male-female PrEP disparities rely somewhat on their largely on their knowledge of male partners' HIV status in that sort of decision tree for PrEP indications, but also stigma, the stigma experienced by women on PrEP, and fear of hostile reactions of male partners and barriers in communicating with healthcare providers are some of the reasons that have been indicated why women may be less equitably served by PrEP than men. And I'll just say this area of PrEP equity differences in men and women is one that we're continuing to work on. I want to wrap up by thinking about so going back to Steph Baral's paper in Lancet HIV a few years ago, what happens when we provide PrEP inequitably to our prevention goals? In other words, what does PrEP inequity ratio tell us about prevention? So these are work of William Godel, who sort of asked this question before we coined this term PrEP inequity ratio, but he laid this out essentially as PrEP to need ratios for Black African American MSM and for white MSM, and just asked the question, what happens if we scale up PrEP in different configurations of equity, essentially? I think you use slightly different terms. And the outcome here is the incidence rate, the black to white incidence rate. So we know that the black to white incidence rate is much higher for Black and African-American MSM in the United States than white. But if we make these kinds of PrEP programs, for example, any place that's sort of on the diagonal here represents what we would call a PrEP inequity ratio of 1. So this would be like a PrEP to need ratio of 10 in Black men and 10 in white men. And when we do that, the incidence rate ratio, when we provide PrEP equitably in any of these along this axis, green means we're reducing the disparity in incidence rate for Black MSM. As you expect, the more PrEP we provide, the bigger that effect is, the darker green that effect is. But these are all like really improving the disparities. And in fact, there are only, I think, maybe 8 scenarios here where we could provide PrEP in a way that made disparities in HIV incidence worse. And if you look at our national PrEP inequity ratio that I showed you before, it's here. So we've managed to land, sorry, that this is these are the sort of equitable programs. We've managed to land in one of the 8% of scenarios in the United States where we actually, our models would predict that we're going to make the Black-white incidence rate ratio worse by the way we're currently implementing PrEP. And this 10 is a national number. It's that inequity is even worse in the South. So I want to wrap up just by saying, how do we use these data to drive change? I'm going to show you where you can access these for your local health jurisdictions. But I want to start out by just advocating that we should be monitoring the success of our PrEP programs using equity metrics and not using count metrics and not using equality metrics. If we program to equity metrics, we'll drive programs to focus resources in proportion to need. So local calculation and dissemination of PNR metrics is important. National, we won't achieve national equity unless we have a series of successes in equity in local areas. And I'll just say, although it's not on the slide, they say what's measured mattered. In some ways, what's reimbursed, will change. And so I just wonder whether there should be some aspect of allocation of resources that says that the cost of reaching people in greatest need of HIV may be higher and should be reimbursed accordingly. So I just want to show you where some of these data are available. This is a state of the county level AIDS prevalence rates for Georgia on AIDSview. PrEP coverage, as I mentioned on the AHEAD dashboard, is shown as the estimated percentage of people prescribed PrEP who need it. So that's available. But what I think I'm advocating that we look at is the PrEP to need ratio. And these are for Georgia. You can see that on the AIDSview site, we have the overall PrEP to need ratio by sex, by race, and by age groups, which I haven't talked much about today. And where you would find these on the AIDSview site is by going to local data. And I'm going to suggest you might want to look at counties. Most of the EHE counties have these data available. So if you click on counties, you'll see a list of the counties, and I'm going to click on Fulton. And so you can actually get these for any of, I think, all of the EHE counties and also by sex and age. I just also want to point out, if you're a researcher, if you go to the tools and resources, data sets, and then you can actually search by state and county, that you'll get a list of all these data sets, including PrEP to need ratio and Excel, that you can download and use for your own analyses. And then I'll mention last that we have infographics, which are available, and this would be probably more to sort of educate in community groups, and where this sort of like pictorial depiction may be more easily translatable. And so these are just some of the examples, but we really try and highlight the differences between, something like the percent of new diagnoses in an area and the percent of PrEP users. So in conclusion, I just want to say, I think these kinds of equity metrics can be applied to everything that we do. And they're easy to calculate. The numerators are the rate of service provision and the denominators are the rate of the outcome. We can do them stratified. I'll just acknowledge that there was some substantial missingness of race data. It didn't vary by region or sex, but we need to do better on that. I mentioned that PNR isn't really a target. It's sort of higher is better. But what it's most useful for is letting us understand inequities between groups. Our calculations might also be impacted by underreporting of HIV diagnoses or misclassifications of pharmacy data. The PNR metric is going to get more challenging as we get higher proportions of people on PrEP, and I'm going to have to leave that to biostatistics colleagues. And we're going to have to try and figure out the coding of 211 dosing schedules in LAI PrEP. I want to share this post that I found on Twitter this morning. I'm rarely on Twitter, but for some reason I looked this morning. And this is I've used the word risk, and I just want to point out that this comment from a physician says, unless you've been in an examination room or a lecture hall where you yourself have been called high risk for your sexual practices, you don't get to comment on how we perceive that language. To continue its use is inflicting trauma on historically neglected communities. So I just want to acknowledge that we do need to think about how we talk about this. And so the language that I've tried to use and to point out that we have a thing called risk in epidemiology, which is a very specific technical, sort of term. And we have to be sensitive about that's heard by communities. So I think using language like getting PrEP to the people who need it most, or getting PrEP to those who are most likely to benefit, takes away the sting of this, this use of the word risk. And just to show you how complicated our professional lives are, I trained as a veterinarian. And so when you get on Twitter, I saw this comment, which I found to be profound and relative to our discussion today. And I also found a very cute picture of a dog who's looking for a name. So if any of you want to get on Twitter, and these owners are asking for a food-related name for this dog. This is the nature of our social media lives. All right, persistent and emerging problems. There are still some issues with the PrEP estimates. They currently exclude Kaiser and VA data. I think this is well on the way to being addressed. We need to do more work for denominators of women with PrEP indications. They're really currently estimated only proportional to indications in MSM, and I think this is a serious oversimplification and a trivialization of the complexity of the risks for women. We're missing race data in the commercial data sets in a way that's certainly not at random. And so when we get this like naive estimation of indications in women and then not missing at random race data, we have sort of interactive misclassification of PrEP indications for women, and then we need to deal with LAI PrEP. So I think prevention programs should be guided by PrEP equity and not equality metrics. And by this measure, the U.S. prevention programs in every region demonstrated decreasing PrEP equity over time. This is worse in the South, and women lag in equitable use compared to men in all regions, and those inequities are sort of not growing as fast, but still unacceptable. And we really need to think about how programs can provide PrEP to communities and people. And I put it in both ways here. When we're talking in ourselves and using risk in the epidemiologic term, we might just say at greatest risk for HIV infection. But we also need to have this language, which is intuitive and responsive to concerns of communities, that we need to get PrEP to the people who will benefit from it most or who will need it most. Getting out the message, we have infographics on AIDSview. We have all the data that you can download on AIDSview. A manuscript on this is forthcoming. And we'll also be putting out additional public use data sets. I want to acknowledge a number of people who contributed to the work in this. And the AIDSview data that we have you can use this QR code to sign up and be notified when there are new data available. So I'll leave that up for a moment as I turn things back over to Ken. Thank you.
Patrick, that was wonderful. Thank you so much. We have about 15 minutes and a bunch of questioners. I think
Good.
you can unmute. Mike Cohn, would you like to ask your questions and comments? So I don't know. If,
And read Mike's comment, which is
yeah.
the recent FIA report from Botswana and other countries seem to recognize the population benefits. I think this is of treatment as prevention. And I agree with that. And I'm not downplaying at all the importance of treatment and prevention. I guess the point I was trying to make was that the treatments will be maximized when we get either of these interventions to the people who are most likely to benefit from them. And in terms of what came up later in the talk, that the reasons for inequitable access are largely social determinants of health. And so it just points out that in all of these settings, that people who are farther away from programs, people who have less access to transportation, stigma, I think, is a common problem between African settings and the US ones that I've talked about. And so I think to Mike's point, I'm not questioning the efficacy of or the effectiveness of treatment as prevention. I'm saying we can get the most out of it when we view it through that lens.
So Jim Pickett has a question about President Biden's call for the $9.8 billion investment in National PrEP program. So what do you think the priorities will do to get closer to equity in the U.S.?
Well, although this is recorded, I'm going to just be a little controversial and say, well, one is that I think we need to, this kind of a program needs to be monitored with equity metrics and not with uptake metrics. I think I've worked in government, and I think a lot of the tendency is to find objective ways to get money from these programs out. And so if there's, resources are provided either on a capitation basis or to programs who enroll a lot of people, that might drive people to enroll the ones they can as fast as possible. And I think to get the most out of the program, there needs to be priority on geographic areas that have large inequities, and for groups, which according to our data are Black and Hispanic people, women, and older and younger people relative to middle-aged people are inequitably served. So I would say my aspiration would be that if these are capitated, if there's a financial compensation provided for the expenses of getting someone on PrEP, that those should be scaled in proportion to the risk in certain communities. And I think that would just recognize that it is actually more expensive and to get the people who would benefit most from PrEP onto PrEP compared to others.
Great. So a question from Jay Lee, and I saw it asked further down as well. Can you comment on using the PrEP equity metrics to look at disparities in persistence or discontinuation, particularly by race, ethnicity?
I think it's a great question. I think the wonderful thing about two wonderful things about Aaron's metric is that there are a lot of, like, the concept of this is pretty straightforward. So I would encourage. I think you could look at the persistence as the sort of positive sort of presentation of this question by race, ethnicity, and then try and use that persistence over a denominator of risk, epidemiologic risk, to see whether the persistence on PrEP is equitable. And so I think the formulation here works for any of these. So yes, and Jaylee, I would encourage you to pursue that. And if I can be helpful in getting you the right data sets or brainstorming, happy to do that.
So do you have any inequity data about people who inject drugs?
Not currently stratified in that way. I think it's a good question. And I think the framework here, we started at the national level, and we started without risk specific. I would just say that the sort of use relative to need by race ethnicity, for example, is inclusive of all like modes of risk. But I do think if we were able to do that, we would probably see some interesting both geographic and by race ethnicity, differences. Again, I think that the data on indications for PrEP are much harder to get, just in that the commercial pharmacy data doesn't necessarily give us indications of that. So I think it's a little bit harder. But yes, they can be applied, but we need to think about how we identify the indications for PrEP in commercial pharmacy. And Julie also asked, applying PrEP equity metrics to assess long-acting PrEP scale up by race and ethnicity. That I think because of the way that the medication will be coded will be more straightforward. I think this methods work that I mentioned, which was the validation of PrEP for the original Truvada product and subsequently the generic equivalent, needs to be applied. We need to do a little bit of checking on Descovy, but also think about how we're going to know when a prescription of PrEP is given and then it's not refilled for 3 months. Does that mean somebody was intending to take daily oral PrEP and just had really poor adherence? Or does that mean that somebody was intending to use event-driven PrEP and had 10 indications for that over 3 months? So I think there's methodologic work that's going to be needed as we have more PrEP options are awesome for the world and an opportunity for researchers.
Yeah. So Colesso asked about new infections. Are you starting to see reduction in new infections as PrEP coverage increases in some of the jurisdictions?
Yeah, there was a paper that sort of made a first step at this a few years ago that needs to be updated. I think it can only be done ecologically with the data that we have, and I think that those analyses I would say are on our list to update as an ecological indicator to help us triangulate a little bit. So it's a great question, and it's not been done to my knowledge yet, but it's on our list.
There's a time lag issue too that makes some of these things a little tricky about some of the assumptions about when people are being reported with new HIV infection as to how long they may have been infected. But Jingling also asks more about PrEP discontinuation among people of color. I don't know if there's anything additional you'd like to comment.
So I think that this idea of trying to quantify, I'm just thinking off the top of my epi head here, but like risk of discontinuation with epidemic risk or with agent risk could be interesting. My speculation is that for the reasons that I talked about of sort of distance to PrEP care, insurance, stigma, so the metrics that we have to do with people sort of starting PrEP, and my guess would be that the same kind of drivers would present challenges to continuation on PrEP, but that needs to be like answered with data and not my thoughts about it. And so I think this is a great question, and the question earlier was also a great question about a PrEP discontinuation and equity ratio. These abbreviations are going to get interesting. PDIR.
Yeah.
Thank you for that question.
Yeah. So Mike has some additional comments about sort of the juxtaposition of PrEP versus treatment, which I think you commented on as already. And Jim Pickett is thanking you for addressing the issue of risk and just sort of debunking its use. So maybe move on to Natalie LeBlanc asking about US born versus non-US born. If there's been any assessment of that in some of these metrics.
A good question, and I think some of these questions are. One is I love working in this community. One, because people are so thoughtful and collegial, but also because you sort of, when you do this kind of work, you feel like you're climbing at least a hill, if not a mountain, and then when you get there, you sort of look out and say, oh wow, there's like a number of other nested questions in here that really have to do with disaggregation. And so the issue with US born versus non-US born, I think would be addressable in it would be challenging to do that on the numerator side for PrEP with the data that we have. I think other folks who work with commercial pharmacy data, I'm really open to hearing about. I know that there are some kinds of products from the companies that make these commercial data sets that can merge with other data sources. For example, we purchase data that are merged between commercial pharmacies and credit reporting bureaus to get certain socioeconomic indicators. And so I have not asked whether country of birth might be available in those data sources, but it would require that kind of merging. Completely agree with your comments, and this is also anti-Black stigma, which is contributing to neglecting care, and that's yeah, it's another part of these complex, multidimensional, intersectional stigmas. So I appreciate that comment, and I will try and see if that's something that we could evaluate. And Taylor, is there data underway to assess measuring equity and PrEP access in states that have implemented statewide legislation interventions like pharmacy prescribing authority authorization? Great question. I won't say, I never underestimate what Aaron Siegler is up to. And so I can't speak to whether this might be underway, but Taylor, I will be happy to just connect you by email to Aaron, and I think he would be the person to ask.
I'm sorry we're running towards the end of the hour, but I see one question that might be of interest to this group from Chenlin Hong about the application of this to global health equity issues and resource limited settings. Have you decided or planning to do any global work with these metrics?
We haven't yet, but I think the elegant thing about what Aaron has really put forward is, the concept that as long as you have measures through national surveys, and I know not every a lot of countries don't have the same kind of national surveillance system, but for example, the FIA data would be a source of risk, and so I think that the concept should be extended, and the question will just be trying to figure out, the building blocks of this are quite straightforward. And so looking in resource limited settings at what the data resources are, and I think that it may be some work to kind of square away, where there are nationally representative samples that might look at the populations with indications, and then aggregating from probably a number of clinical settings rather than from commercial pharmacy data.
Yeah, the other question Chenlin had was about telehealth and whether that might obviate the PrEP desert issue. So do you have any data or any thoughts you want to share about that?
Yeah, no, I think that that it has the opportunity both to deal with PrEP deserts and potentially with some of the stigma, issues and discomfort talking with providers. I think one issue that I'll just flag is that the laboratory pieces which support this are, as they are growing, that we need to pay attention to the regulatory aspects of the monitoring, because the telemedicine-based PrEP requires the mail out of kits, and I just say that's an issue that we need to keep our eyes on and make sure that that we're in a good regulatory place for those, because I think they've sort of emerged quickly, and there may we got to make sure they're on solid ground in a regulatory sense.
Well, I apologize to those for whose questions we weren't able to answer. Patrick is very responsive, so I suggest you may want to get in touch with him directly after this talk if you have any burning questions. It was a really wonderful talk, and I think, Patrick, we should be doing this on a regular basis so that you can update the group on this really important work. And thank you so much for your presentation. And thank you, everyone, for participating. And a reminder, next month, we will have another session with Connie Kellum and Jen Velosa, which will hopefully be equally stimulating. So thank you, everyone. Have a good day.
Thank you so much.